a very good evening to all the esteemed members of the Nephro Critical Care Society, as well as all the attendees across the globe. Welcome to the fifth installment of our Nephro Critical Care webinar series. And we are really privileged to have you all. And thank you for showering your support as well as appreciation for our previous webinars. Today, as the General Secretary of the Nephro Critical Care Society, I am delighted to introduce our esteemed speaker, Professor Dr. J.V. Peter, sir. He is the former director as well as the Professor of Critical Care Medicine at CMC Vellore, the prestigious CMC Vellore. Everybody knows it. So we are fortunate to have him as our speaker for the evening. And we are also fortunate to have our esteemed panelists. The first, Dr. Sarmili Sinha. She is the senior intensivist from Apollo Hospital, Bhubaneswar, India, as well as she is the vice president of Indian Society of Critical Care Medicine. Next, I welcome Professor Dr. Subhas Prasad Acharya, very dear colleague, and he is the professor and head at Department of Critical Care Medicine, Tribhuvan University, Kathmandu, Nepal. And last but not the least, in our panelist league, I welcome Dr. Preeti Meena. She is the assistant professor, Department of Nephrology from AIMS Bhubaneswar, India. And with me, I also invite as well as welcome Dr. Sananta Kumar Das, the facilitator from Australia. She's about to join. She's in the hospital now for some urgent call. And also Dr. Jacob George, who needs no introduction. He's also our organizing chairman for the upcoming Nephro Critical Care Review course, which is just one day after on Saturday and Sunday at Caritas Hospital, Kottayam, India. Now, we are after this talk by Professor Dr. J.V. Peter, we will have a scintillating quiz, which is again the ice on the cake of our webinar series. So that would be presented by Dr. K. Swarnadeepak. He is a young dynamic intensivist, senior consultant at Critical Care Department, Apollo Hospital, Hyderabad, India. So I welcome all of you to the fifth installment of our Nephro Critical Care webinar series. So to just move ahead with the topic, we tonight will tackle the challenging, I would say the challenging topic of diuretics in critical care. One of the widely used, I would say, drug in critical care as well as nephrology. And none other than Professor Dr. J.B. Peter would take us to the journey of the diuretics, what all we should know about this very important, I would say, the therapy in critical care medicine. So with this, I request sir to please start the session. And I would request all the panelists, if there would be any questions, so please take all those questions at the end of sir's presentation.
Is the slides seen?
Yes, sir.
Yes, sir.
Okay. First of all, I want to thank the organizers for this opportunity to present this topic, which is diuretics in nephro critical care. I'm not sure whether I'll be able to cover all that you should know, because when I started reading, I realized how vast this subject is. So I focused my talk on what an intensivist should know about nephro critical care, and tying in with that other aspects of diuretic use in the ICU setting. But there will be a lot of focus on nephro critical care. So for my talk, I'm going to start with an overview of diuretics. How are diuretics used in the ICU setting? What are the reasons for which we use? I'll then touch upon diuretic resistance and its management, and then I'll conclude. Now, if you look at the term diuretics, what does it mean? Diuretics actually are agents that decrease sodium reabsorption at different sites and increase urinary sodium and water losses. If you talk to a pure pharmacologist, they'll say diuretic is not a correct term. It's a natriuretic, because that really specifies what it does. But diuretic is the most commonly used term in our clinical practice. they want to distinguish that from what is called aquaretic, which the function of which is to increase free water excretion. The classical example are the vasopressin 2 antagonists at the collecting duct. Strictly speaking, these agents are not diuretics. So the first class is natriuretic and the second class is aquaretic. Now, how do you classify diuretics? We'll use the term diuretics because we are so used to using the term. We can classify it based on the site of action in the tubular segments of the nephron. And there are 5 sites at which it acts. We can also classify them based on the mechanism by which they inhibit transport of sodium. And again, there are 5 categories. Based on the site of action, the natriuretics work on the proximal tubules. They are called proximal diuretics. They can act on the ascending loop of Henle, which is the loop diuretic. They can act on the distal convoluted tubule, or they can act on the cortical collecting tubule. And this picture depicts how much of the sodium is reabsorbed in the different segments. And as you can see, the amount that is reabsorbed is maximal in the proximal tubule, and the second is at the loop of Henle. The collecting duct site, they are the aquaretics. Now, based on the site of action, we have different examples. The proximal diuretics include the carbonic anhydrase inhibitors and the new class of antidiabetic agents which have diuretic properties, which are the SGLT2 inhibitors. We have the loop diuretics, which are the most frequently used diuretics in the ICU setting. The examples are furosemide and the rest which are there. Those that act on the distal convoluted tubule, we have the thiazides, metolazone, indapamide, and others. In the collecting tubule, we have the sodium channel blockers and the aldosterone antagonists. These are the potassium sparing and diuretics, amiloride, trimethrin, spironolactone. Those which act in the collecting duct, the aquaretics, include cornivaptan and tolvaptan. Now, based on the mechanism of action, we have 5 classes of diuretics. They are the carbonic anhydrase inhibitors, which act by inhibiting carbonic anhydrase. The loop diuretics, which act by blocking the sodium potassium chloride symporter. The osmotic diuretics, which act by osmosis. The potassium sparing diuretics, which act on the epithelial sodium channels and the mineralocorticoid receptors. And the thiazides, which act on the sodium chloride symporter. To add to this, we have the SGLT2 inhibitors, which, as I said earlier, acts in the proximal convoluted tubule. Now, putting all this together, we have the proximal tubule, convoluted tubule, in those drugs which act on that. They are the carbonic anhydrase inhibitors and the SGLT2 inhibitors. And the classical examples are the acetazolamide and dapagliflozin. Those which act on the thick ascending loop, the loop diuretics, the classical example is furosemide. Those which act on the distal tubule, classical examples are metolazone and thiazides. Those which act on the collecting tubule, the aldosterone antagonists, and those which act on the collecting duct, the vasoreceptor blockade agents. Just briefly touch on the dose of diuretics. The commonly used ones are furosemide and torsemide, and the dose of furosemide ranges from 20 to 480 milligrams per day in divided doses. Torsemide, 5 to 40 milligrams per day. Chlorothiazide, hydrochlorothiazide, dose of 12.5 to 50. Sorry, from 125 to 500. The hydrochlorothiazide is 12.5 to 50. The chlorothiazide, as I said. The thiazide-like agents, the commonly available ones are chlorthalidone, indapamide, and metolazone, and the doses are given on this slide. When we go on to the potassium sparing, the amiloride and trimethrin, doses are 5 to 10 and 50 to 150. Spironolactone, 25 to 100. The carbonic anhydrase inhibitor, that is acetazolamide, 250 to 1000. Mannitol, which we give as a 20% infusion, and tolvaptan, which is used at the dose of 15 to 60 milligrams per day. Briefly on the bioavailability and elimination, the loop diuretics, particularly furosemide, is completely eliminated by the kidney, whereas the other loop diuretics have elimination through kidney and liver. The thiazide group are predominantly eliminated by the kidney, and the distal convoluted tubule agents are eliminated both by the kidney and the liver. And as you go on to spironolactone, it's completely eliminated by the liver. We'll quickly finish off the effect of these agents on the electrolytes and acid base. Broadly, almost all diuretics cause a potassium loss. The exceptions are the potassium-sparing diuretics and the SGLT2 inhibitors, which can have a neutral or a potassium increasing effect. Again, almost all the agents have decreased calcium levels except the potassium-sparing one and thiazides. Magnesium loss again is present with all diuretics except potassium-sparing and SGLT2. Urate levels actually increase with most drugs except the SGLT2 and the osmotic diuretics. Sodium increases with loop diuretics, could increase or decrease with potassium-sparing SGLT2, baptans, and variable effect on osmotic diuretics. And the hydrogen ion concentrations reduce. They become more alkalotic with the loop diuretics and could become more acidotic with the carbonic anhydrase inhibitors, potassium-sparing diuretics, and the osmotic agents. So we now move to the focus of this talk, which is the diuretics in the ICU setting. And again, when we look at the indications, we can base it on the class of diuretics. So I'll go through each of the diuretics and take you through what are the indications that we use them in the ICU and with some evidence that we have. Secondly, we will go through, based on etiology, disease processes, and what are the role of diuretics and some evidence for that. So first, we look at indications for diuretic use based on the class of compounds. We'll start with the first one, which is acetazolamide. And this is used to treat the metabolic alkalosis, which is due to diuretics or steroids. Some people use it for the treatment of permissive hypercapnia and the metabolic alkalosis, which results due to permissive hypercapnia in COPD patients and in nasogastric suctioning. I generally prefer not to use this unless the pH crosses a very dangerous threshold, 7.65 or 7.7. And most often, the metabolic alkalosis that is created in the ICU environment is due to the therapies that we do or the way we ventilate patients or the underlying disease process like a COPD. Now, acetazolamide can cause metabolic complications like acidosis, hyponatremia, and hypokalemia. And hence, in the ICU setting, we always prefer to give just a single dose of 250 milligrams if the patient is severely alkalotic. Check the pH before you administer further doses. With long-term use, calcium phosphate stones can happen, and there can be allergic manifestations and hepatotoxicity with acetazolamide use. The second group of drugs is the osmotic diuretics, and there are a whole heap of indications, and we'll go through them. The classical renal indication is the prevention of AKI, and it's said to work by removing obstructing tubular cause, dilution of nephrotoxic substance in the tubules, reduction of the swelling of the tubular elements. It has been recommended earlier for the treatment or prevention of rhabdomyolysis associated acute kidney injury, particularly when the urine output is more than 300 ml per hour. As you know, one of the contraindications for using drugs like mannitol is that the renal function should be relatively preserved, because if the mannitol is not excreted, then the patients can go into pulmonary edema. Mannitol can also act as a myoglobin related free radical oxygen scavenger, but studies have shown that mannitol is not superior to saline. There have been studies that have looked at the use of mannitol for the prevention of contrast-induced acute kidney injury along with saline, but again, the use in this setting may be more detrimental, and we stick to the conventional hydration prior to administering contrast. The one indication where there is some evidence that the osmotic diuretics may help is in the setting of prevention of ischemia, reperfusion, injury in kidney transplantation. And there's a recent meta-analysis that suggests that mannitol may reduce the incidence of ischemic reperfusion injury. And of course, the classical use in the ICU for reduction of ICP in patients with cerebral insult and raised ICP, we do use mannitol. Of course, the adverse effects are dilutional hyponatremia and potassium loss, and high dose mannitol therapy can cause osmotic nephrosis due to renal vascular constriction and tubular toxicity. Moving on to loop diuretics, furosemide. It's a diuretic of choice in 90% of acute kidney injury with fluid overload. It's also used in decompensated heart failure and in several metabolic derangements. It can be used as an adjunct in treatment of hyperkalemia, but the potassium excretion with furosemide use is variable. It can be used in the treatment of hypercalcemia, but again, studies have shown that it does not add significantly to the effect of hydration in reducing calcium levels. And there are studies which have shown that bisphosphonates are the most effective in reducing calcium levels. In type 4 renal tubular acidosis, it helps acidify urine and decrease potassium levels. Forced diuresis for drug toxicity, again in the ICU setting, in the setting of drug toxicity, this can be used as an adjunct. The mode of administration, there have been studies that have looked at continuous infusion versus boluses. The continuous infusion is recommended, although there is no strong evidence to support the superiority of continuous infusion over boluses. And this is recommended because of less variability in the concentration. There is a more predictable diuretic effect, and there could be less diuretic resistance and side effects like autotoxicity and effect on electrolytes. In a randomized control trial that looked at continuous infusion versus infusion and heart failure, there was no difference in mortality or length of stay. However, the diuresis was better with infusion as compared to bolus. Furosemide also has a role in the furosemide stress test in acute kidney injury. We'll come to that in the next slide. The metabolic effects, you all know, it can cause a huge range of metabolic effects. The furosemide stress test, although this was postulated several decades ago, has gained a lot more popularity in recent times. And furosemide is a better loop diuretic to predict renal tubular integrity, as it is not filtered and its function is completely dependent on tubular function. Furosemide-induced urine output can be used as a marker of severity of acute kidney injury. And what is done is we challenge with IV furosemide, 1 milligram per kg if the patient has never been on furosemide, or 1.5 milligram per kg if the patient has been on a prior use of loop diuretic. The response that we're looking at is a urine output of at least 200 ml over 2 hours. And if the urine output is less than 200 ml over 2 hours, it has an 87% sensitivity and 84% specificity to predict patients who are likely to progress to akin 3. In fact, studies have suggested that it's a safe test in the critically ill, and it's even a better predictor than an NGAL to predict progression of acute kidney injury. What about other loop diuretics? Compared to furosemide, torsemide, and bumetanide have more favorable pharmacokinetic profiles. There's one study which has compared, randomized study which has compared torsemide versus furosemide on renal failure and cardiac surgery patients, and both were found to be effective in increasing urine output, but torsemide fared a little better as it had a better dose-dependent diuretic effect. In non-hospitalized patients, torsemide also is postulated to decrease left ventricular remodeling and reduce mortality, but that is outside the ICU setting. What about distal convoluted tubule diuretics? Its role is in fluid overload. It is used in diuretic resistance. In a database of 7,645 ICU patients who were requiring more than 1 milligram per kilogram per day of furosemide, nearly half the patients received a second diuretic class, and the major one was a thiazide. Thiazide results in greater weight loss, but there is also a higher risk of hypokalemia. The second use is in ICU-acquired hypernatremia. There is a potential benefit because thiazides cause more sodium loss, but the randomized control trial did not show a significant effect of thiazide on serum or urinary sodium. Its adverse effects, again, there are metabolic adverse effects and allergies. Now, there are several thiazide options, and the potency, relative potency, the oral bioavailability, the half-life, and the estimated time of effect is seen here. Uh, we don't use too many of these drugs in the ICU setting. Metronidazole is sometimes added when there is diuretic resistance. We also sometimes use hydrochlorothiazide as a second drug when patients are not mobilizing fluids. We'll come to that in a separate section. Moving on to potassium sparing diuretics, these are generally not used in the ICU setting because most situations in the ICU are those which cause an increase in the potassium. There is in the same ICU database study which I had talked about earlier, it said that the study showed that the combination of a potassium sparing agent with furosemide actually reduced the 24-hour urine output. However, I must add that we do use potassium sparing drugs in patients who present with heart failure who come to the ICU after we stabilize them with loop diuretics and add an ACE inhibitor. If the potassium is still low and the renal functions permit the use of spironolactone, we do add spironolactone even in the ICU setting for severe heart failure. What about vasopressin receptor antagonists, predominantly used in SIADH, but it's also used in hypervolemic hyponatremia, which is refractory to fluid restriction. But I must add that there is hardly any evidence in the ICU setting, but there's some evidence in hospitalized patients, and we'll just go through the use of vasopressin receptor antagonists both in the OP setting and the hospitalized setting. In the outpatient setting, in hypervolemic and euvolemic hypernatremia, the two studies, SALT-1 and SALT-2, tolvaptan increases sodium concentration by day 4 as well as urine output. In the hospitalized non-ICU setting, the study is Everest, 4,133 patients in heart failure. It improved sodium levels and dyspnea and edema, but it had no effect on mortality. The only evidence that we could locate was in 6 ICU patients who were refractory to more than 60 milligrams of furosemide, tolvaptan increased diuretics without any side effects. The usual side effects with these drugs are thirst, dry mouth, and polyuria. What about SGLT2 inhibitors? These are novel new agents that are used for the treatment of diabetes and heart failure with reduced ejection fraction. Again, these drugs have been mainly evaluated in the outpatient setting, and in the hospitalized setting, it has not really been evaluated because of the risk of euglycemic ketosis, and there are no ICU-based studies. The use of SGLT2 inhibitors was studied in a randomized control trial in COVID-19 admitted patients, a fairly large study. And this study showed that the use of dapagliflozin tended to reduce the incidence of multi-organ dysfunction, including acute kidney injury, versus placebo. The difference seems to be very small, but this seems to be a promising use in the hospitalized setting and in sicker patients. The other studies, I just summarized the DAPA-HF and EMPEROR-reduced placebo-controlled trials in class 2 to class 4 heart failure with reduced ejection fraction. There is a reduction in the risk of worsening heart failure or death from cardiovascular causes with dapagliflozin and empagliflozin. In the DAPA-CKD study, where patients were enrolled with eGFRs of 25 to 75 ml, the risk of CKD progression was lower with dapagliflozin than placebo at a median 2.4 years. Again, as I said, these are all studies more in the outpatient setting and in the hospitalized. There are very few studies in the hospitalized setting, but more in the setting of heart failure. But this seems to be a very promising drug for the future. So having finished each of those classes of drugs, or each of the drugs, and looking at what are the indications in the ICU setting, let's look at the indications for diuretics based on etiology. Now, there are 5 broad headings where we use diuretics: volume overload, acute heart failure, acute renal failure, severe hypertension, and cerebral edema. I'll focus on the first three because those are the more important ones. Now, there is a lot of study recently in volume overload in the setting of shock. We all know there is an ebb and flow in patients with shock. There is a 4-hit model of shock where initial fluid resuscitation is the fluid resuscitation followed by optimization of fluids. Subsequently, there is stabilization and there is evacuation or deresuscitation. And if the deresuscitation is very aggressive, there may be a risk of hypoperfusion. When we look at the 4-hit model of shock and its impact on organ function, the first bit where patients come in shock, they are hypovolemic. And then as we resuscitate them, they become normovolemic after fluid resuscitation. And if the fluid resuscitation, which is generally aggressive, they go on to fluid overload. And then with deresuscitation, they become normovolemic. And at the end, there is a risk of hypovolemia with hypoperfusion of the organs. Now, what are the consequences of this fluid overload? We can have renal effects, hepatic effects, gastrointestinal, cardiovascular, respiratory, and central nervous system consequences of this fluid overload. So much so, there is this concept that has come up, which is called the fluid stewardship, like the antibiotic stewardship, where there are 4 aspects that are looked at. The first aspect is when to start fluids. Second is when to stop fluids, when to start removal, and when to stop removal. Now, there are 2 terms that we use actually interchangeably. One is fluid accumulation, and the second is fluid overload. Now, the term fluid accumulation is a pathologic overhydration, whereas fluid overload suggests intravascular hypervolemia. Now, as you know, in the ICU setting, patients may be quite edematous and have a lot of accumulated fluid, but they may not be fluid overloaded. In the sense, they may not be intravascularly hypervolemic. They may be, in fact, intravascularly normovolemic or hypovolemic. And in these states, we have to be careful with the use of diuretics. Now, this fluid accumulation is defined as more than 10% fluid accumulation, calculated by the cumulative balance over the days in liters divided by baseline body weight into 100. So if somebody has baseline body weight is 60 kgs and they have accumulated 6 liters positive balance, then you would say that they have had fluid accumulation. Now, there are 2 components that we need to look at in the stewardship. One is called deresuscitation, and the second is de-escalation. Now, de-escalation just means reducing the amount of previously administered fluids, whereas deresuscitation is the active fluid removal in overloaded states using drugs, that is the diuretics, and in some extreme situations, you may also use ultrafiltration. Now, what is the effect of positive fluid balance and diuretic use and outcomes? It's a very nice study that was published in Critical Care in 2019, which looked at 7,828 patients, and they looked at the effect of diuretic use on mortality in the ICU cohort. They found that 11.3% was the mortality amongst the 1,469 patients who received diuretics versus 18.4% being the mortality in those who did not receive diuretics, 6,359 patients. Then they looked at whether, it's a function of diuretic use or a function of positive fluid balance. And they found that in patients who had positive fluid balance, who had diuretic use, there was a reduction in mortality with an odds ratio of 0.64 and a confidence interval which was quite narrow. However, in those patients who had a negative fluid balance, if diuretic use was used, there was no mortality effect. Now, on propensity score matching, 1,463 cases in each group, the mortality remained lower with diuretics. So this effect was pronounced even after matching for severity. So how do we resuscitate? As I said, fluid restriction and de-escalation. The drugs that are used are loop diuretics, potassium-sparing diuretics, thiazides, and there is probably a small role for carbonic anhydrase inhibitors. If the albumin is low, albumin can be infused along with furosemide for synergistic effect. And if the patient drops the blood pressure, we often use a small dose of noradrenaline. And my take on this is, as long as the NORAD doesn't go up beyond, say, 5 to 10 mics, we are happy to use diuretic therapy along with a norepinephrine to deresuscitate. In deresuscitation, you also need to ensure that the cardiac function is optimized, because the cardiac contractility is poor, renal perfusion suffers, and then that can compromise deresuscitation. In extreme situations, you may offer ultrafiltration as a means to deresuscitate and get patients off the ventilator. So how do we make the choice in deresuscitation in terms of fluid overload? The first agent of choice is loop diuretics. So you first start with the loop diuretic, see if you're able to meet the targets for deresuscitation. If not, the second add-on drug is distal convoluted tubule drug like a thiazide. And if the patient has metabolic alkalosis with the vigorous diuretics that we have, or when there is a diuretic resistance with the first and second line agents, then carbonic anhydrase inhibitors can be used. If there is persistent hypokalemia due to diuretic use, potassium-sparing drugs can be added. And if there is hyponatremia, vasopressin receptor antagonists can be used. Moving on from fluid overload to acute heart failure. Now, loop diuretics are the cornerstone for the treatment of heart failure, but surprisingly, in a topic that is so important, and we have so many patients coming with worsening of heart failure to the ICU, there are sparse clinical trials to guide use. Loop diuretics have a steep dose response curve, and the plateaus are often reached at commonly used doses. Now, these are actually, the loop diuretics are called the ceiling drugs. Basically, beyond a particular dose, you have a ceiling effect beyond which you don't have an increase in sodium excretion. But additional natriuresis occurs by increasing the time during which plasma diuretic concentration exceeds diuretic threshold. So you need to keep the diuretic level concentration higher above a particular threshold to continue to have the ongoing diuresis. Now, what are the goals of loop diuretics in heart failure? The first goal is to achieve negative short-term sodium chloride and water balance, and it's called decongestion. So you want to have a negative sodium balance and a negative water balance in the short term. And in the longer term, you want to reduce the extracellular fluid volume. Now, there are two problems or phenomena that we see in patients who are administered furosemide for diuresis. The first is called the post-diuretic sodium chloride retention. Now, the dose of loop diuretic increases urinary excretion for a few hours. So it increases urinary excretion for a few hours. And then when the effect wears off, there is a period of post-diuretic sodium retention. So the sodium retention occurs during the phase after the diuretic effect wears off. And this needs to be kept in mind when we are using diuretics. The second effect is called diuretic breaking. Now, as you use repeated doses of furosemide, you find there is a reduction in the effect of diuretics, and this is called diuretic breaking. So these two mechanisms need to be kept in mind when we're using diuretics in any volume overload state or in heart failure. Now, as I said, there is very limited evidence for the use of diuretics in heart failure. There is this dose study, which was published in the New England Journal of Medicine in 2018. This actually was published earlier than that. This is summarized in a review article in 2018, where it was a factorial design that used IV furosemide twice a day as bolus or infusion, and low dose furosemide, which is equivalent to what the patient was taking previously, or a high dose, which is 2.5 times the previous dose. All patients also received IV bolus every 12 hours and a continuous infusion, one of which was furosemide, and the other was saline or placebo, a saline placebo. So it's a very complex design. It's a factorial design, but the take home from this was that the high dose performed better in terms of symptom relief from dyspnea, change in weight gain, and net fluid loss. But this was at the cost of a slight increase in creat of about 0.3 milligram percent over baseline. This is more frequent with the higher dose of furosemide. But what is encouraging is that this increase in creatinine was not necessarily related to a poor prognosis. So what is recommended in heart failure is 2.5 times the daily dose of a previously oral dose administered twice daily as IV boluses. Now, what are the other adjuncts that you can use for treatment of heart failure? There are three agents that, and there are trials for this. The Everest trial, there is no superiority of tolvaptan for long-term outcomes, although there was short-term improvement in volume status and symptoms. The second study looked at furosemide with dopamine or necessitide, the ROSE-AHF trial. Neither trial affected urine volume or cystatin C. However, in a subgroup of patients with reduced ejection fraction, dopamine may enhance decongestion. But as you know, we don't like dopamine in the ICU setting. We call it bad medicine because of a lot of systemic side effects. So this part of the observation, that is in patients with heart failure, with reduced ejection fraction, as an adjunct to furosemide, dopamine to enhance decongestion needs further study. So, and the third one is spironolactone, and the study is Athena HF study. It did not affect primary endpoint of decongestion of symptoms. Now, if all these fail, there are extracorporeal therapies, that is ultrafiltration, that have, there are 4 trials. The first is the UNLOAD trial, which showed a decrease in heart failure admissions. The second one is the CARES HF trial, which did not show a difference in mortality. The cohort trial, which again showed a 1-year difference in readmission rates. And the last one is the AVOID HF trial, which showed did not show a difference. So the evidence is both ways. So if the patients are refractory to diuretic therapy, you may even require extracorporeal removal of fluid to treat heart failure. The third dimension of diuretics, which I want to focus on, is diuretics in acute kidney injury. And what is the basis for its use in renal failure? There is experimental data that shows that furosemide reduces oxygen and metabolic requirements of tubular cells and increases oxygen concentration in the medulla. And hence it is postulated that it may be beneficial in early acute kidney injury and prevent progression and or reduce the severity of AKI. So this is the basis on which furosemide has been tried in the setting of acute kidney injury. So there are 3 questions that we ask in this setting. First is, does furosemide benefit in early acute kidney injury and prevent progression? And there's some evidence for 3 meta-analyses, 2 of which included 5 studies and 1 which included 9 studies. The second question is, are diuretics effective in restoring renal function in patients on RRT? So first one is prevention of progression. Second one is this, once they've developed acute kidney injury and they are on RRT, does it help in restoring renal function faster? And we have the results of the SPARK study and some evidence from the other studies also. And the third one is, do diuretics help in treating fluid overload in acute kidney injury? And I'll start with that. It may have a role because if the patient is still responding to responding to diuretic therapy, and if they are fluid overloaded and they are symptomatic, the use of a diuretic may help convert an oliguric AKI to a non-oliguric AKI and make fluid management easier for us in the ICU setting. There are, however, no trials that have really looked at it. Let's move on to the other 2 questions. The first one is the 3 meta-analyses that looked at prevention of progression of AKI to needing dialysis and the time to dialysis. Now, if you look at mortality, there is no difference with the use of furosemide in the setting of AKI or for the risk of renal replacement therapy. The relative risk is 0.99 with a confidence interval of 0.8 to 1.2. So there is no effect of furosemide on progression of AKI. But one of the three meta-analysis was a Bayesian analysis where they suggested that probably dialysis rate may be reduced and there may be a reduced oliguric period. So in a patient with AKI, there is no harm in giving diuretics as a challenge to see whether the kidney will open up. The furosemide stress test will tell you whether the patient is likely to progress or not. And if the patient responds to furosemide, you may start on an infusion, and that is likely to reduce the time to dialysis and the dialysis rate. The SPARK study, as I said, was a randomized trial, no difference in worsening AKI or kidney recovery or RRT. So the second question is also answered that those who are already on RRT, it doesn't hasten renal recovery, the use of diuretics. Now, summing it all up, it's a very nice article which talks about the 10 myths about furosemide. It's worth reading. It's an intensive care medicine. So let's say, when do we administer furosemide? Furosemide is administered if the patient is at risk of AKI and is in a fluid overload state. So this is on the right-hand side of the equation. However, if the patient is at risk of AKI and they don't have a fluid overload, it is potentially harmful. You could administer furosemide along with albumin if there is diuretic resistance. And third, if there is AKI with fluid overload, again, furosemide has a role. Where there is no difference in the use of furosemide is in weaning of RRT. And there's again no difference between continuous versus intermittent infusion. You should avoid furosemide in patients who do not have fluid overload, as this may cause harm. Now, moving on to diuretic resistance. What is diuretic resistance? How do you diagnose diuretic resistance in the setting of acute heart failure or acute kidney injury? I'm taking this separately because the nephrologists seem to prefer a definition. The cardiologists seem to prefer a slightly different definition. So we look at both definitions. We look at the mechanisms of diuretic resistance and prevention and treatment. Now, diuretic resistance is the failure to achieve the therapeutically desired reduction in edema despite a full dose of diuretic. The alternative definition is the diuretic effect weakens or disappears before the therapeutic goal is reached of reducing edema. And the incidence is about 20 to 35%. And we can look at diuretic resistance in kidney disease and heart failure, in chronic liver disease, but I'm going to focus mainly on kidney disease and heart failure. Now, what about diuretic resistance and heart failure? Now, it is defined as a 2-hour spot urine sodium. The 2-hour urine spot sodium can, after loop diuretic, can facilitate early recognition of impaired diuretic response. And those with congestion, the hourly urine output of less than 100 to 150 ml during the first 6 hours and or spot sodium of less than 50 to 70 millimoles 2 hours after a loop diuretic indicates an adequate response. Now, if you look at the curves on the right-hand side, you have the diuretic response in a normal individual. And if you see in chronic heart failure, the curve shifts right and downwards, indicating relative diuretic resistance in this group of patients. Whereas in chronic renal failure, the curve shifts to the right, this is the blue one, owing to impaired diuretic secretion. So here, diuretic resistance is after diuretic, urine output of less than 100 to 150 ml, and or a spot sodium of less than 50 to 70 millimoles. In AKI, it is defined as a fractional excretion of sodium of less than 0.2%, urine sodium of less than 50, or a urine sodium par potassium ratio of less than 1. So there's a slight difference in the definitions. Now, what are the causes? One is diuretic resistance may be mistaken for actually venous or lymphedema. Diuretic resistance can be due to non-adherence to water or salt restriction, drug not reaching the kidney due to non-adherence, low dose or infrequent dose or poor absorption, reduced diuretic secretion, that is decreased tubular uptake in uremia due to reduced blood flow, or decreased functional renal mass, or there is insufficient kidney response to disease as in low GFR, decreased intravascular volume, activation of renin-angiotensin system, nephron adaptation, and the use of NSAIDs. So what are the mechanisms of diuretic resistance and acute kidney injury? Electrolyte disorders can cause diuretic resistance. Hypochloremia can cause renal stress injury and decreased blood flow. Hyponatremia affects transport of iron transporters. Potassium fluctuations, both hypo and hyperkalemia, can also contribute to diuretic resistance, and high urea nitrogen levels also can contribute. In addition, hyponatremia, hypoproteinemia, and changes in pharmacokinetics and pharmacodynamics, and nephron injury due to a host of factors can also cause diuretic resistance and acute kidney injury. In the cardiac setting, there is diminished oral bioavailability because of reduced absorption, impaired drug delivery, impaired sodium delivery because of low perfusion to the kidneys, and there is also distal tubular remodeling and the breaking phenomena, which all contributes to diuretic resistance in the setting of heart failure. How do you prevent? Strict adherence to salt restriction, closely observing renal functions and picking it up early, avoiding hypoalbuminemia and correct when necessary, and avoiding drugs that interfere with diuretic action like NSAIDs, steroids, and estrogens and cimetidine. How do we treat? Correct electrolyte disturbances and hyponatremia. To change the dose or add other diuretics like thiazides, metolazone, and in extreme cases, we may have to resort to ultrafiltration to overcome diuretic resistance. There are some experimental use of glucocorticoids and mannitol. I'm just adding it for completion's sake. This is more in experimental models, so we wouldn't advocate it in the setting of humans. So there is an algorithm that has been proposed for managing diuretic resistance. On the right-hand side is the established pathway. So the urine output, as I said, is assessed at 2 to 6 hours. If the urine output is more than 150 ml, then continue the same dose and repeat the assessments. The urine output is less than 150 ml, then we administer IV loop diuretics at double the dose and repeat diuretics up to 300 milligrams of furosemide equivalent. That's quite a stiff dose. And if there is failure to meet in the urine output or sodium excretion, then you add the first line drugs, which is thiazide, or the second line agents, which may include acetazolamide, amiloride, or aldosterone antagonists. On the left-hand side is the emerging pathway, which is based on the urine sodium. If the urine spot sodium is assessed at 1 to 2 hours, if it's more than 50 to 70, then continue the same therapy. If the urine sodium is less than 50 to 70, then you follow the same pathway. So both the pathways merge to the center. One is based on the urine spot, and second is based on the urine output. So to summarize, diuretics are an important class of drugs in the management of several disease processes. In the ICU setting, it has a role in heart failure, acute kidney injury, deresuscitation, cerebral edema, and hypertension management. Loop diuretics are the most frequently used diuretics. Combinations may be required in some settings, and diuretic resistance is not uncommon. Thank you so much.
Thank you, Dr. Peter, for this elaborate presentation. I don't think there are any other stones unturned in terms of diuretic use in the ICU. I will open the discussion to the panelists if they have anything to add or any other questions.
Thank you so much, Dr. Peter. It was a very lucid presentation. We gained a lot out of it. I just want to come as a nephrologist. I just want to comment or convey my message to the attendees that we oftenly misuse, sometimes overuse, or sometimes underuse these diuretic, because sometimes a lot of time I got references that the patient is in fluid overload, but the primary team is not giving diuretics, saying, especially resident, they say, ma'am, it will cause AKI further. The creatinine is already 2.3. I want to say that if there is a fluid overload in an AKI patient, please use diuretic. It could actually prevent or delay RRT. We may not want to immediately start RRT. We may wait and want to see the response of diuretic. Unnecessary, it will increase the rates of intubation and dialysis and these things. So you may use, and there's a term used as a permissive hypercreatinemia. So even if there is small increase in the creatinine, that is okay. It may not indicate AKI. It may just be the hemodynamics or hypersecretion of the creatinine in these kind of patients. So you may use this diuretic. Even in nephrotic syndrome, most of doctors are not using diuretic, saying AKI will occur and a lot of things is happen. Eventually, they will land up in diuretic resistance or underuse of these diuretics. Patient will go in pulmonary edema. Prolonged hospitalization will be there. So we should actually use them judiciously. I would also like to see if there are any questions for the speaker. Are there any?
I had a point to what Dr. Preeti said.
Yeah, sure.
I fully endorse what you said. When I was a resident in training, I was told furosemide never kills.
Yeah.
Use it. And the second point is, often in the ICU setting, we all faced with a dilemma. Which organ do we prefer or favor? Do you favor the lungs and keep the patient dry and sacrifice the kidney, or do you flood the lungs and favor the kidney so that the kidney will not fail? Now, I've always inclined more towards favoring the lungs because it's not too difficult to support the kidney, and you can easily titrate the dose of diuretics and make sure that the patient doesn't go through the roof. Whereas once the lung is flooded, you can't ventilate, you're in deep trouble.
Yeah, so we
And
should,
ECMO is much more
actually
difficult.
early use the diuretic. Also, sometimes the clinical symptoms are not that relevant. For example, it's a bedridden patient who is in ICU. He may have pedal edema, and we may be using diuretic and causing a lot of AKI. Here, there could be intravascular volume loss. So here we should see whether AKI will happen with diuretic. We should use them or not use them. That's up to, we can use now. POCUS nowadays is very trending, so we can use these technologies to assess what are the clinical symptoms. Are they correlating with the other things in a patient or not?
Yeah, it's an excellent narrative on the use of diuretics in intensive care unit. I think we all have seen a question in the chat box regarding use of the osmotic diuretics, that is mannitol, in cases of obstructive jaundice. Is there any role? That is one of the questions. And though I have answered it live, I would like to hear from Dr. Peter his views.
I'm sorry, I've never used it, so I'm happy to listen to your words of wisdom on that.
Yeah, in my experience, we have never used or neither would advocate use of osmotic diuretic like mannitol in patients of AKI and with obstructive jaundice for that matter. However, having said that, in clinical practice, I have come across some situations where some of the hepatologists would be inclined towards prescribing mannitol for patients who have obstructive jaundice and probably developing grade 2 or 3 of hepatic encephalopathy as an anti-cerebral edema measure for those patients, rather than thinking of AKI in that setting. So I would be surprised if you're trying to prescribe the osmotic diuretic, that to mannitol, for a patient in AKI with obstructive jaundice. Certainly not a wise choice. And my second question to you, you presented in your slides that there have been multiple various permutation and combinations of clinical situations or organ dysfunction in a patient in ICU. You mentioned about when you're using group diuretics, more of hyponatremia. Is that more common, or hypernatremia is more common in your practice?
Both are common. Both. Offhand, I think in the ICU setting, we tend to see patients drifting more towards hyper than hyponatremia, because you tend to sort of deplete them not only intravascularly but intracellularly. They may look boggy, but intracellularly they're depleted. The creatinine goes up, sodium goes up. But we do see hyponatremia also, not uncommon. Both we see.
In my practice, actually, it's always been quite perplexing to see more of hypernatremia in these patients, and especially if they're on if they're on infusions or the classic dose of, say, 20 milligram IV TDS doses, which is a very favorite dose of the cardiologist. And once it starts touching 150, it's very difficult to bring it down, because you are, of course, not going to give them, dextrose, something which is a free water equivalent, to bring it down. And it becomes a vicious cycle, and many times it adds to your ICU acquired psychosis as well. So I think we have to be judicious. If your sodium is studied trending up, we have to be judicious where it will bring down your doses of furosemide in those cases. Dr. Meena, you like to comment on that?
Yeah, I actually see both hypo and hypernatremia, both are common in our patient, especially more in nephrotics patient and AKI. We mostly see hyponatremia rather than hypernatremia. Hypernatremia mostly in ICU settings and clinical setting, other in wards, and we mostly see hyponatremias rather than hypernatremias in our community settings and daily OPD basis with the use of as a complication.
I think, Dr. Sharmili, that is a very valid problem in ICU, because on day 3 of the diuretic use, we'll have the patient with a sodium of 150, which keeps on trending up. So it's more common than appreciated. I think the usual practice, what we do is we start the thiazide diuretic or a metolazone with it on day 2, day 3. That reduces the chances of having hypernatremia. Day 2, day 3, if you add a thiazide or metolazone, the incidence of hypernatremia is slightly less, but not zero. So it is a valid problem actually. It is a drawback that once we start furosemide, we'll see that in 72 hours for sure.
Mostly because most of this patient would be having concomitant diabetes also, and once it touches that, there is a frequent immediate prescription of 5% dextrose, and then it goes on. Your fluid limit order is also not obeyed. It becomes a kind of anti-thesis of this.
Yeah.
Thanks for your views. I can see one question or a comment from Dr. Subhash.
And that's not me actually.
Okay.
So I accidentally shared my panelist link to all my residents and colleagues. So all of my residents and colleagues are popping in as panelists. Extremely sorry for that. In fact, before we move on to
one
that,
more question. Yeah, you can read it for if you want to.
I was trying to talk about the previous issue that Dr. Peter and we're discussing about the AKI, diabetes in AKI. My concern and issues is that here I'm from Nepal, and most of the residents, in dosing of diuretics in AKI, like we tend to use loop diuretics, and when there is AKI, and the residents are giving the dose, they're starting with the 10 milligrams of furosemide, and then saying that okay, this is not working, and then again we, as we try to explain the pharmacokinetics and the dosing issue, it takes some time for the residents to understand that we need to go up higher on the doses, and they tend to be more reluctant on giving higher doses of diuretics in patients who are AKI volume overloaded, and they expect diuresis with low doses of furosemide. What do you have to say anything on this to our residents, or any?
I trained under an Australian intensivist who was very bold with diuretic challenge. And when the patient is anuric and has AKI, and you say, let's give 250 milligrams of IV furosemide to turn the kidney on. When I came back to India and started using this, it raised such an eyebrow for nephrologists and intensivists. So I came down from 250 to 125 to 80, now to 60. So I go for a standard 1 milligram per kg diuretic challenge. And if there is a reasonable amount of urine output, I don't aim for 200. If I get 60, 80 ml with that bolus, then I start an infusion at 10 milligrams per hour. So in a person who's fluid overloaded, where you are struggling to manage fluids, you're needing to ultrafiltrate daily, I would give a diuretic challenge of 60 or 80 milligrams, 1 milligram per kg. If there's some urine output, start an infusion, makes your fluid management much easier. 250 people do give, but I become, as I become older, I become more cautious. I'm happy to hear others' views on how much they use in a person.
So I also use start with a 1 mg because as we discussed here, they have a ceiling dose, so you have to reach the ceiling level and give a bolus dose, then you can use intermittent. So I also use 1 to 1.5 mg per kg of diuretic, and I actually both furosemide and torsemide good, but in severe cases of renal dysfunction, I believe that torsemide works better in case of renal dysfunction, CKD patients, especially CKD patients.
I may differ in that because it depends on how the patient is. Patient with a naive kidney, they usually do well with a 10 milligram and they will pee out 3 liters of urine. And which is a usual thing. But patient who has a background of CKD, you may need 250 milligrams. So it based on how the patient presents and what's on the background. So somebody who has come with some sort of bowel surgery and now has a low urine output, and you want to, whether you say kickstart the kidney or not, but she will require a very low dose to start it. And if you give a higher dose, then you may be harming. But somebody with a CKD coming with further fluid overload and not passing much urine, then in that case you may need a very high dose. So it depends on how the patient is at the baseline, I believe. That's my personal experience, not based on any robust data, but I do tend to go a bit conservative with patients who have a naive kidney, like no CKD in the background, young patient. They usually do better with very low dose, like 10 milligram, 20 milligram. They will pee out 3 liters of urine with that.
Yeah, just a quick response to what Dr. Subhash asked is about residents being hesitant to use higher doses of furosemide. Is one of the possible reasons I could imagine is about their ability or confidence in assessing the state of fluid overload. Because as we heard Dr. Peter and all the literature or the practice evidence supporting, and it has a role in patients who have got fluid overload, either AKI or cardiac failure, whatever you're talking about. But if a patient just has presented with AKI and you're not sure if the actual patient is fluid overloaded or not, it may be in the setting of OPD or in the wards or in the ICU. I think that is what the new beginners, they're hesitant about using this kind of high doses of 1 to 1.5 milligrams of furosemide per kg doses. But I think once if you're certain that there is an element of fluid overload, it definitely makes a case for administration of that kind of dose. But I agree with Dr. Peter and Dr. Meena that it's 1 to 1.5 milligram max that we use in our practice, never crossed 100 in my experience of 20 years so far.
Ma'am, if I can.
Yeah, please.
So I would like to be on the devil's side. So as of now, I agree. There's another beneficial effect is the venodilation effect in an acute heart failure. It definitely helps with the preload reduction. One study we've done in our institute is where the people who were treated with the loop diuretics, especially furosemide, they tend to have a lot of ototoxicity as well. We have done the patients who shifted to from the unit, and it's very underdiagnosed, and in most of the time they're once the patient becomes free of the fluid, they'll feel better, they're sent home. I don't know what are your thoughts, because we observed, at least my personal observation is there definitely will be some kind of ototoxicity. Any one of you, please?
The problem is more with protracted use. If you're going to use it for a day or two of high dose therapy and wean down quickly, there shouldn't be a problem. But prolonged exposure to high dose furosemide is likely to cause ototoxicity.
True, sir. True.
Yeah, I think it is also quite under-addressed.
Yes. In fact, when I started the study, everyone was literally behind me. So, but I think we do tend to do.